Now let's talk about another category of conditions called autoimmune diseases. Now, when we talk about autoimmune diseases, we have to think again, we mentioned this earlier, that you tend to involve females and during reproductive age, because what sex has to deal with the immune system because is going to be the female, because obviously when they get pregnant, they have a lot of foreign antigens from the contribution from the paternal side, and so they have to be in an immunosuppressive state. So they have finely tuned their immune system in such a way to control rejection of this fetus. So therefore, they're exquisitely sensitive to mechanism of suppressing the immune system. So therefore, if there is perturbation to these immunologic suppressive, then what can happen is it can also lead to autoimmune disease where you get a hypersensitivity response to self-antigen. And we'll talk about conditions like systemic lupus erythematosus and others in a moment. Why reproductive age? Because it's very stressful biochemically and hormonally. And so that's why you're also seeing self-antigen. When you think of menses, when you have the shedding of the endometrium, you're exposing self-antigens. And so now you can have a immunologic response to it. And if it's uncontrolled, it can therefore lead to an autoimmune disease like systemic lupus erythematosus. What's another common denominator when you think of autoimmune diseases? You want to find out what is the antibodies being made to specific epitopes that can be classified, and what is the one part of the cell that's sequestered from the immune system is the nucleus. So a lot of the serologies that are developed to help define what type of autoimmune disease you want to give the patient in terms of approaching the patient in terms of prognosis and obviously treatment is ANA, or anti-nuclear antigen. That's found in all autoimmune disease, so it's non-specific. So as we go through each of these autoimmune diseases, there are specific antibodies to different epitopes in the nucleus that are used clinically to make the clinical path correlation of making the diagnosis of various autoimmune diseases. What is a common denominator in all autoimmune diseases that you always have to remember is that because they have an abnormal immune system, they can be prone to develop what two complications is going to be opportunistic infections, and the other, because the immune system was developed to fight off microbes, and the second is because you have damaged or a genetically susceptible immune system, that you have dysregulation of these cytokines that are being released by helper cells, T cells, macrophages, that what can happen is dysregulation over a period of time in certain individuals can lead to proliferation of lymphocytes, and you have to worry about lymphomas developing as a complication within the setting of an autoimmune disease. And what do you think of that can produce these lymphocytic neoplasms? You think of conditions like Sjogren's, as well as Hashimoto's thyroiditis, where in both of these they have an influx of lymphocytes into the tissue, and they're proliferating, and as cells proliferate, when you get to neoplasia, you increase the mutation rate, and out of that can evolve a malignant phenotype, in this case, non-Hodgkin's lymphoma. How do you make the diagnosis of autoimmune diseases? Is obviously clinical path correlation. You may require serologies, obviously, as well as biopsies to confirm your suspicion of what this disease, and so epidemiology is important. So let's take these various conditions one at a time and see what's common and what is unique to like any set of conditions. On exams, remember that when they choose one of these conditions, and you don't know which one they're choosing, they're really trying to see if you understand the underlying principles involved when you think of autoimmune disease and how you use common sense in terms of approaching and understanding the pathogenesis. So systemic lupus erythematosus, the name, as you can see, systemic and involving multiple organ systems. So in terms of hypersensitivity reactions, in order to cause this much organ involvement, you have to have which hypersensitivity reaction are immunocomplexes circulating and being deposited in multiple organ systems that will lead to acute immunologic damage and lead to dysfunction of that organ that's affected. And so you're going to produce autoantibodies, and the one organ system that tends not to have immunocomplexes involved, but another way of using hypersensitivity reaction is the hemopoietic cells. In that case, remember we talked about earlier in the condition called ITP, or immune thrombocytic purpura, is where you have antibodies to platelets. So what you see in the bone marrow in SLE patients is antibodies to platelets. We call it ITP in the chronic form, or you have antibodies to red blood cells, and now you can lead to autoimmune hemolytic anemia as a consequence to this. So why do they call it lupus? Another important word. Lupus means wolf. So anybody who reads Harry Potter chapter in the book 3, The Prisoner of Azkaban, there was the professor of dark arts, and if you recall, his name was Professor Lupin because he was a werewolf. So wolf, because when you look at the wolf bane, or the face of a wolf, you get that characteristic malar rash. And what does malar mean? It doesn't mean a butterfly. It means the region of your face called the cheek. And what does erythematous mean? It means what color is the rash? It's red because of the vasculitis, because of the deposition of immunocomplexes within the vessels since it's circulating. So you can see by this one definition, medicine is very descriptive. And if you know what it means, then the clinical vignette, they may not tell you the patient has SLE, but will give you the features that will define. So the one book you want to do well on the USMLE is open up that medical dictionary and do not get paralysis of your finger on the mouse. Click it. You're one internet click away to finding out what it means. Don't be lazy. Epidemiology. When you think of SLE, it's primarily, like most autoimmune diseases, in females. It has a predilection to occur typically in reproductive age, but it has a propensity to be early on in reproductive age as adolescents, as well as 20s and 30s. It can be more common and more severe in African American females. Why versus Caucasian, no one really knows. The autoantibodies, there, as I pointed out, be found in all autoimmune diseases, would be anti-nuclear antibodies, so it's going to be non-specific. But what is unique to SLE is antibodies to double-stranded DNA, and as well as antibodies to the Smith antigen. And another important thing they can bind to is histone antibodies, and also that one can find, you can get antibodies to lipid. You get anti-phospholipid. And it's not to the lipid, but the lipid bound in the serum is also bound. Cardiolipin is the specific lipid that binds to a protein, and so this is also unique in SLE. When we talk about the mechanism of injury, again, I mentioned earlier in the introduction of autoimmune diseases like SLE that when you talk about it's an immunocomplex base, it's circulating, causing vasculitis, because those immunocomplexes will eventually get deposited in the walls of vessels and various organs, leading to vasculitis, thrombosis, infarction, and because of hypoxic damage. Versus the hemopoietic system, it'll be antibodies to platelets and red blood cells, leading to either hemolysis or thrombocytopenia. So the distribution of the disease, hematologic, we just mentioned, is hypersensitive to reaction, hemolytic anemia, thrombocytopenia, and in certain situations you can also make antibodies to neutrophils, leading to neutropenia. So what type of infections will these patients have an increased risk for? Fungal as well as bacterial infections. Lymphopenia, you can in certain situations make antibodies to your lymphocytes. And immunocomplexes like to go to what? To joints, leading to arthritis, leading to polyarthralgia, as well as synovitis. And you won't get deformation of the joint like you think, like in rheumatoid arthritis. It likes the immunocomplexes go to the skin, hence the lupus malar rash, because it gets deposited not only in the blood vessels in the dermis, but also will go into be deposited along the basement membrane between the epidermis and dermis. You activate complement, PMNs come in, and now the epidermis can basically detach from the dermis, and you can get a blistering. And then if there's enough ischemic damage because of the vasculitis in the dermis, it will then lead to basically ulceration in that area that's affected by the deposition of immunocomplexes. So you get that famous malar rash, but it affects both cheeks and the bridge of the nose, but it also can be on the forehead, the chin, and other parts of the head. Why the head? Because you think of the high vascularity to the head, that'll about 30 to 35% of cardiac output goes to the head. So where if you're an immunocomplex like to travel, to those tissues that have a lot of blood flow. And so you can get this raised papular red rash and lead, as I mentioned before, to ulcerations and blistering. What do we use the term blistering? Bullae formation. Another place in terms of immunocomplex damage that can occur is the kidney. Since about 15 to 20% of your cardiac output goes to the kidney, if I'm immunocomplex, that's where I'm going to go as well. And it's one of the complications of SLE is renal failure. And the World Health Organization classification goes the following. You don't have to memorize this for the exam. They'll never ask this, but this just helps you to see how it's being stratified when you talk about SLE patients. In the class 1, you may not see any morphologic changes, but there'll be renal dysfunction. The immunocomplexes can be going to the mesangium, hence we call it mesangial lupus nephritis. It can also go to a few glomeruli. We call that focal proliferative glomerulonephritis, because what's going to happen when these immunocomplexes gets deposited in the glomerulus, it can initiate the release of cytokines like cells like macrophages on the outside of the glomerulus or the mesangial cells, leading to proliferation of mesangial cells and or podocytes, for example. Then you have type 4, which is diffuse proliferative glomerulonephritis. It's the most common and severe that one sees in SLE, and hence when you say diffuse, as you recall, that it's going to involve all the glomeruli in the kidney and a proliferative state. The second most common glomerulonephritis in the kidney of SLE patients is called membranous. Now remember, those glomerular diseases, they look very difficult, but they're very easy, because when they give you the term membranous glomerulonephritis, they're describing what it looks like under the microscope. And when you think of membranous, what is happening here, these immunocomplexes are being deposited along the glomerular basement membrane in a subepithelial distribution. So if you add material to this capillary wall, what's going to happen to the wall thickness? It's going to become thicker, and the term that describes this is membranous. And that tends to give you a nephrotic syndrome. Because these immunocomplexes are circulating, they're going to travel through, obviously, the pump, in this case the heart, and it can irritate the endocardial surface, and a famous endocarditis is Liebman-Sachs. Then these immunocomplexes can be deposited in the blood vessels, in the capillaries, in the pleural surfaces, as well as the peritoneal, so you get pericarditis, pleuritis, pleural effusions, because of the inflammatory process being initiated by the deposition of the immunocomplexes. It can also go to the CNS, since it's highly vascularized, producing a vasculitis, and that can lead to thrombus formation, lead to occlusion, ischemic damage, and then they can lead to anything like seizures, to psychosis, depending if it's small vessel disease. And so it'll be important in the differential when you have patients that come in at this age and sex, that you have to think of an immunologic basis for these neurologic symptoms. When we talk about SLE in terms of treatment, like all autoimmune disease, how do you treat them? Steroids and immunosuppressive agents. The prognosis is fairly good at 5-year survival rate, as long as there's early intervention and patient education. The remission and relapses can occur depending upon how severe the disease in that individual is affected. The survival rate at 10 years is now 85% with good management and follow-up care. Death is usually due to, as I mentioned earlier, because of the deposition of immunocomplex in the kidney is renal failure, but usually that can be treated with either dialysis and or transplantation. But again, if they still have immunocomplex, even the transplant kidney can be affected and lead to permanent hemodialysis or retransplantation. But remember, when you have an autoimmune disease, you're immunocompromised, plus you're on immunosuppressive drugs. Therefore, you have to worry about opportunistic infections, and be similar to like patients who have AIDS, that you have to worry about fungal infections like candidiasis, for example, as well as viral infections like CMV, herpes simplex. So you always have to remember that. Another important autoimmune disease is Sjogren's syndrome, or SECA. SECA means what syndrome? Means dry. So now we're talking about autoimmune disease that's characterized by the destruction of lacrimal glands. Obviously, you're going to have dry eyes. And then an important thing that provides moisture to your oral cavity is the secretions from your salivary glands versus major and minor. and basically you're going to have dry mouth. So the clinical features, again, it's predominantly in females, usually in reproductive age, in the latter part of reproductive age, middle age, and remember middle age is defined as what? The age of 40 and beyond is middle age. And basically, what do we call it clinically when you have dry eyes is keratoconjunctivitis sicca, and it can also lead to corneal erosions or ulcerations because of the inability to make tears. And then obviously the lack of salivation in the mouth will lead to xerostomia. Remember, xerostomia means opening, or in this case the mouth, or dry mouth. And it can also be associated with a syndrome called Michelwitz, where you get an enlargement of the salivary and lacrimal glands, and it's due to the infiltration of lymphocytes into these glands that's leading to destruction of the secretory acinar units, leading to the various dry areas in the eyes and mouth. The other thing you should remember, you can be associated with other collagen disease. The one that's always going to be asked on the USMLE is rheumatoid arthritis. And you can, if somebody has rheumatoid arthritis and dry mouth or dry eyes, you can make the diagnosis of Sjogren's. And what are the unique autoantibodies in the nucleus is going to be to ribonucleoproteins, and the ones that are often associated with this is SSA or SSB. And then what is the complication you have to worry about because of this lymphocytic infiltrate within these glands is the proliferation of lymphocytes, increasing the mutation rate, leading to non-Hodgkin's lymphoma, which, as you recall, are primarily B-cell neoplasms. Another disease I'd like to ask about is scleroderma, or progressive systemic sclerosis. Another important autoimmune disease is scleroderma. Sclero meaning what? Hardness. In this case, it's hardness due to the deposition of collagen. Another clinical term for this is progressive systemic sclerosis. So who's going wild in this disease is the fibroblast. And who's controlling the fibroblast is a macrophage. And so this is an autoimmune disease characterized by zealous fibroblasts laying down a lot of collagen, who are going to be stimulated by the macrophage. And collagen, as you go back and think about where you see lots of collagen would be the skin and internal organs, and lead to dysfunction at these various sites. So again, this is autoimmune disease. It's more common in females versus males. It can occur, again, reproductive age. Usually in the middle of reproductive age is the peak incidence, but again, it can have a range between 20 to 55 years of age. Again, the pathogenesis is the activation of fibroblasts to lay down collagen by the release of cytokines like IL-1, platelet-derived growth factor, and fibroblastic growth factor, obviously leading to fibrosis. And the source of this is coming from primarily the macrophage. When we talk about scleroderma, there are various subtypes. The first type is called diffuse scleroderma. And by this term, it means that there's diffuse fibrosis or sclerosis throughout the body. And the unique antibody that's associated with this is antibodies to DNA topoisomerase 1. And this is also called CL for Ch07b. And it has widespread skin involvement. And what's the problem with having too much fibrosis? Let's think about this with the skin. When you have so much collagen and you have these myofibroblasts, remember we get contractions. So you're going to get sclerodactyly in the hands will contract. But we have to now think of our anatomy. Remember on the USMLE, you may not have direct questions of anatomy and histology, but you need to know the basic histology of every organ system. Because now when you have a disease like scleroderma, destroying the dermis, and what is being found in the dermis are adnexal structures like hair follicles. So the constriction on blood vessels there will lead to degeneration, destruction of these adnexal structures. What if you destroy the sweat glands? What's going to happen to the skin? It becomes dry, it cracks. If you now impinge upon the blood vessels supplying blood, it can lead to atrophy of the skin, breakdown of the skin, ulceration, and lead to a variety of problems in terms of function of the skin. It'll be harder, stiffer, therefore function of extensibility of the skin is going to be diminished, and leading to problems like, for example, dexterity of using your fingers is going to be diminished, and now you're going to have the inability to perform simple tasks as simply writing your name or basically using a cell phone like an iPhone. When we have in this condition, diffuse scleroderma, it can be early involvement of visceral organs. Obviously, those tissues that have motion in it, like the esophagus, if you have too much collagen, can make it very stiff, so interfere with peristalsis, then leading to dysphagia as the complaint by the patient. Then, obviously, if you have too much collagen, it's going to increase the thickness of the wall, diminishing the ability to absorb and leading to malabsorption syndrome. And then, obviously, if you have deposition of collagen in the lung, you're going to increase increase the thickness of the wall of the alveolar walls because of the scar tissue, but you will decrease the oxygen diffusion capacity, leading to the most common symptom would be what? Dyspnea, either at rest or in exertion, depending on how severe the fibrosing process is in the lungs. Obviously, if you have fibrosis in your heart, it's going to make it less compliant. So now you're going to have what type of primary or cardiomyopathy would be what would be called restrictive or infiltrative cardiomyopathy. And remember, if you decrease the compliance of the heart, what part of the cardiac cycle are you affecting is the diastolic phase. And then, obviously, if you lay down collagen and destroy the nephron of the kidney, you're going to lead to chronic renal failure. So then we come to a second category called CREST syndrome. And the CREST syndrome is a localized scleroderma, and we'll talk about what CREST stands for in a moment. The unique antibodies is to the centromere of chromosomes. It can involve the skin and face, and if they show you a picture on the USMLE or if you see a patient clinically, you'll notice that if it's on the face, you see a middle-aged woman, what will be missing will be wrinkles, because you can imagine the contraction of the skin, pull back, and you can see certain people who have gone to a plastic surgeon where the surgeon has overstretched the skin and it looked like the patient has scleroderma, but it's really the zealous surgery of the plastic surgeon that leads to this appearance of scleroderma. And you'll see this in famous actors and actresses that have facelifts. They look like they have scleroderma. So basically, when it involves the skin and face, you're going to impair the ability of the function. And when you talk about the CREST, it'll eventually involve the visceral organs, but later in the clinical context of the disease process. So we talk about CREST syndrome. What does the C stand for? Because you have degeneration to tissue and you get this fibrosing process, you can get deposition of calcium or form of dystrophic calcification. Then we come to what is called the R. Raynaud's phenomenon. This is what we would call secondary Raynaud's phenomenon. Later in the cardiovascular system, under the vasculitides, they talk about primary Raynaud's and secondary Raynaud's. So when we talk about primary Raynaud's, or what used to be called Raynaud's disease, this is a young female under emotional stress or cold stimuli, gets vasoconstriction in their hands, become painful and pale. If you did a biopsy of these patients, you would find no morphologic changes in the blood vessels. Now, when we talk about Raynaud's phenomenon as secondary, what would you expect to see? You would have the same signs and symptoms that I just described for primary Raynaud's phenomenon, but in secondary, what you would find that's leading to this process is fibrosis around the blood vessels, and that would be secondary. What's another autoimmune disease that we've just discussed that can also lead to Raynaud's phenomenon is SLE. In that case, what you would see as a consequence of vasospasm, or you see vasculitis because of the deposition of immunocomplexes in the areas of that are giving you the Raynaud's phenomenon. Another clinical feature is esophageal dysmotility, again, because leading to dysphagia, sclerodactyly, where the hands contract down because of this fibrosing process. And then we come to telangiectasia. What does tel mean? Tel means like a telomere on a chromosome, telephone, telescope, it means the end. In this case, the end blood vessels. And what is ectasia? Is dilatation, because you can imagine with the scarring process in the skin, for example, what's going to happen is that you're going to constrict down on blood vessels. Obviously, what's going to collapse first would be typically the venules, and then blood backs up and cause dilatation of the vessels, leading to telangiectasias. And again, it has a relatively benign clinical course in general. Another autoimmune disease that will be revisit again when we get to the skin is what is called dermatomyositis or polymyositis. This is an autoimmune disease where you have cytotoxic T8 cells destroying the skeletal muscle fibers. And basically it's, again, typically seen in reproductive females, considered an autoimmune disease. So it can involve just the muscle itself, many muscle groups, or it can involve not only the muscle, but also the skin. We call it dermatomyositis. And often this is going to be antibody mediated, but again, you can in the skin, but you also see cytotoxic T8 cells as well. It can often affect women in the latent reproductive age and lead to muscle pain and atrophy, and particularly involving the shoulders because of muscles that are found in that area. And when it basically involves the skin, you can get rash around the eyelids, purple-red in color. It has a pattern called heliotrope that one can see in these patients. And both have increased serum creatine phosphokinase because of the damage to the muscle itself, and sometimes you may even see anti-nuclear antigen as well.